two major issues. One is the sensation and another the emotion. And that actually is accompanied by anxiety. And patient urge to escape or get rid of this feeling. If you consider the spectrum of chest pain, there is a wide range of disease symptom as simple as simply musculoskeletal pain in one end to a fatal life-threatening acute coronary syndrome or pulmonary embolism on the other hand. Among chest pain of cardiac origin, there is also a wide range of clinical spectrum as simple as a short-lived angina with little muscle damage to a massive, extensive damage of the muscle as in acute myocardial infarction, even in sudden cardiac death where you don't have much time for damage, but still the patient present as a chest pain. So if you go to the real world scenario, chest pain is one of the most common complaint of patient presenting in emergency department and accounts about 10% of the patient. Out of this, about 5.5 patients present as a life-threatening situation needs immediate attention. In USA, the patient presenting chest pain in emergency department, about 60% patient admitted for evaluation, 40% are discharged. In UK, it's about 30% get admitted for evaluation and 70% are discharged. Of this, about 60 to 65% patients are evaluated, finally diagnosed as a non-cardiac. What an irony. Because of this, there is a good number of patients being admitted of multifactorial reason. One is that maybe the insurance coverage, maybe the fear of the physician about legal issues. Even then, about 16% patients never reach to definite diagnosis. And interestingly, about 2 to 5% of the patients presenting with acute coronary syndrome are misdiagnosed and being discharged without giving any treatment, life-threatening situation. And it is one of the major cause of litigation against the emergency physician. So the main objective of evaluation of chest pain is to rapid and accurate assessment of acute chest pain of cardiovascular origin, to recognize the life-threatening non-cardiac cause of chest pain, to understand and initiate the basic initial therapy for patient with acute chest pain, and also minimize the cost and hospitalization in a patient with chest pain of low risk category. So we need to differentiate the pain. If you consider the differential diagnosis, it could be cardiac, which is the major cause. There are also a good number of patients having non-cardiac cause of chest pain. So among chest pain of cardiac origin, it can be chronic stable angina, where the patient complain very little about chest pain on a day-to-day basis, but usually they complain of effort angina, means that when they do physical effort, then they get chest pain. The other end is that acute coronary syndrome that include unstable angina, non-STMI, STMI. Apart from that, from the ischemic, there is other non-ischemic cause of acute chest pain, like in aortic dissection, aortic aneurysm, pericarditis, mitral valve prolapse. There are a number of non-cardiac causes of chest pain, and it is not easy to remember. So if you can classify in the heading of some organ specific, then you can at least remember a good number of etiology of non-cardiac pain. Like pulmonary, if you consider is from the lung origin, it could be because of bronchospasm, tracheitis, pleuritis, pneumonia. Hello. Am I? Hello?
Sir, carry on, sir.
Oh, sorry. There was a little disturbance. Sorry. If you consider the etiology and the heading of gastrointestinal, it could be because of esophageal spasm or reflux, maybe esophageal tear, as commonly known as the Malarious disease, maybe because of peptic ulcer disease, gallstone, pancreatitis, etc. And the headline of musculoskeletal could be costochondral or epidemic myalgia and reef fracture, maybe chest wall injury. And in miscellaneous, it could be herpes zoster, thoracic outlet syndrome, prolapse disc or spinal nerve compression pain. That also can refer on the chest. The splenic infarct, fibromyalgia, and maybe panic or anxiety related. But considering all these things, one should not miss the major cause. That is, if in the heading of ischemic heart disease, it could be stable angina, unstable angina, non-STMI, myocardial infarction, pulmonary embolism, aortic dissection, pneumothorax. These are life-threatening situation which need immediate attention. So one should not miss at least these four etiological cause of chest pain. Regarding the chest pain, there are, as I have showed, there is a number of causes of chest pain. But if you take a history very carefully regarding the location, radiation, character, precipitating factor, relieving factor, associated feature, you can differentiate and also come to a conclusion about the etiology of chest pain. Say, for example, if you consider the location wise, if it is ischemic origin, usually it is central or diffuse, but it is not like other non-cardiac cause like peripheral or peripheral located. In terms of radiation, usually cardiac pain radiate to the jaw, to the neck, to the shoulder, inner aspect of the arm, but in non-cardiac is not as such what we are seeing in ischemic origin. Regarding the characteristics, usually the chest pain of ischemic origin, patient complain of tightness, squeezing, choking, and precipitated by emotion or exertion or cold exposure. And it's relieved by rest. On the other hand, there is not that typically what we see in ischemic heart disease compared to non-ischemic origin. Because of this ambiguity of the nature of the chest pain, there's a one scoring system to identify the probabilities of coronary artery disease. If consider the location as a substernal, exertional, relief by rest, these three things. If somebody has got one, then it is said non-anginal chest pain. If it is two, then atypical chest pain. If it is three, it is a typical chest pain. It is the scoring been given by Diamond Forrester. And typically, the angina factor is usually retrosternal and diffuse, not localized, worsened by activity, emotion, cold, and relieved by rest or sublingual GTR. It usually radiates to arm, lower jaw, or sometimes in the back. It has a duration more than a minute, as opposed to second or hour for the other cause of non-cardiac chest pain. But in case of diabetic patient, particularly in female, they rarely you find the typical chest pain. Sometimes the patient complain like dull, constricting, choking, or heaviness, squeezing, crashing, and they express more by his posture and gesture rather than by telling anything. The expression shows that it's anxiety, sweating, pallor skin, stressing hand on the chest. It shows that he cannot express, but the severeness can be identified by seeing his face. So this is a typical character. We call it a Levin sign. This is a very characteristic sign of chest pain of ischemic origin. And these are the location, usually the location of the chest pain, maybe sternal, and the jaw, radiates to arm. These are the figure shown. So apart from the typical symptom, usually to identify the coronary origin, there are other suggestive symptoms like palpitation, dizziness, syncope, weakness or fatigue, dyspnea or PND, sweating or vomiting. These are the associated symptoms with which you can identify the cause of pain as ischemic origin. And you also need to correlate these things with the possibilities of coronary artery disease if it is associated with some other risk factor like hypertension, high cholesterol, smoking habit, diabetes mellitus, family history of coronary artery disease, obesity, and physical inactivities. So with all these things, you can identify the etiology of chest pain. There are a number of patients. It's very difficult to understand in emergency department whether it is cardiac or non-cardiac. So there are a number of scoring systems which can identify the patient as their probabilities. One of this is emergency department assessment of chest pain score, EDACS ADP. ADP was the addition with ECG and troponin, and all together it is a 34 in number, the scoring. And if it is less than 16, is low risk, means that the less probability. But if it is more than 16, it is not low risk. The term is not low risk means that you need to evaluate this patient. It need to be given attention. With this scoring system, at least 30 to 40% low risk patient can be identified. Although it has got less specificity for chest pain, but it is very sensitive in detecting the 30 days major cardiac events. Similarly, another score is heart score. That includes the history, ECG, age of the patient, risk factor, troponin. So here also the score is 10. So out of this 10, if somebody has got less than 3, it is low risk. If it is 4 to 6, it is intermediate. This means that may or may not. But if it is more than 7, it is high. So the patient having chest pain with a low risk, like less than 3, you can discharge the patient and investigate as an OPD basis. But in an intermediate patient, you need to observe the patient to come to a conclusion about the possibilities of coronary artery disease. And if it is more than 7, you definitely need the patient to be in the hospital for management. Another conventional chest pain is also it is scored about 10. If it is more than 4, it is a highly sensitive in detecting the high risk patient, although it has got no role in detecting patient of low risk. Here also it's sensitive in identifying 30 days miss. So after this history and physical examination and also ECG and biomarker, you need some other test to come to a conclusion about the etiological background of this chest pain, like chest X-ray, echocardiography, treadmill test, about dobutamine stress echo, myocardial perfusion imaging, ultrasonogram, CT angio, and coronary angiogram. So after that, taking the history, physical examination, 12-lead ECG, and cardiac marker, the patient with chest pain fall at least one of the 4 categories. Either it's a non-cardiac diagnosis, or maybe a chronic stable angina, or possible acute coronary syndrome, or definite acute coronary syndrome. So in the patient with suspected acute coronary syndrome with low or intermediate probabilities, what we scored from the previous scoring system, with the normal ECG and normal biomarker, we can go for a stress test. And it can be done in emergency department extension chest pain clinic, or it can be done in outpatient department basis within 72 hours. It's a class 1C indication. And other cases, if the patient is suspected with acute coronary syndrome with lower intermediate probabilities of coronary artery disease, in whom 12-lead ECG and biomarker are normal, here we can go for a CT angiogram as an alternate to stress test. And it is class 2A indication. And disease. So now I will go to the acute coronary syndrome. Acute coronary syndrome basically is the most common cause of chest pain and serious cause of chest pain what we encounter in OPD. It's referred to as any constellation of clinical symptoms that are compatible with acute coronary syndrome that include ST elevated MI, non-ST-MI, or unstable angina. And if you understand the pathology behind this acute coronary syndrome, you can identify the actual etiological background and also subsequent management. Say, for example, this is the animation of the patient with the coronary artery disease, slowly progressing the uh, atherosclerotic plaque. Up to this, it progressed over the period of decades without much symptom acutely. But the patient will complain of effort angina once the luminal diameter effort angina means that there is an imbalance between supply and demand. This patient, if been untreated, it will progress slowly, where there is ulceration of the endothelium covering the plaque, producing acute plaque rupture with initiation of coagulation cascade. So there will be formation of clot, which can be which can be uh, partially occluding or subtotal occlusion, give rise to unstable angina or non-STMI. And ultimately, it will progress to completely close the vessel. That leads to acute closure of the vessel and is responsible for our acute myocardial infarction, what we need to do immediate attention for the patient. So the acute coronary syndrome has got a clinical spectrum of unstable angina, non-STMI, or STMI, and by the evidence of troponin means that muscle damage, there is nothing or none in unstable called non-STMI associated with ECG change of maybe ST depression. And in STMI, there is definite rise of enzyme associated with ST elevation. In all this case, acute MI, there will be appearance of the Q, but in non-STMI or unstable angina, if it is first time, you will not get QM. But if it is under the situation of previous acute previous myocardial infarction, then you may get QOM on the ECG. So unstable angina or non-STMI, principally three presentation. One is the rest pain prolonged more than 20 minutes, new onset of pain with class 3 angina, or crescendo angina, means that previously diagnosed angina that has become distinctly more frequent, longer in duration, and lower in threshold. This is acute coronary syndrome in terms of unstable angina or non-STMI. And if you go through first identify the ECG with ST elevation, it will be ST elevated MI. If you do enzyme, if it is positive, then without Q, it is non-STMI. But if enzyme is negative, then it is called unstable angina. This differentiation is to plan for treatment, because each of these different nomenclature given on the background of the pattern of treatment a patient will get. And for the treatment of unstable angina and non-STMI, the patient should be hospitalized and given loading dose of aspirin, clopidogrel, anticoagulant. Especially we used to give low molecular heparin. We'll give GTN, beta blocker, statin, morphine if there is any pain, and oxygen if there is hypoxia. This is a typical history of ST elevated MI. I deliberately wanted to show this ECG to everybody who are seeing this program, just to memorize these things to have a visual impression of a patient with acute MI, ST elevated MI. This very typical ST elevated MI is so dangerous, we call it M complex. And it is one of the major cause of sudden cardiac death because it initiates arrhythmia like VT and VF. So any patient, if any doctor or physician see ECG like this, he should take immediate measure to avoid a fatal complication. And if you analyze the last 50 years development of management of STMI, there was tremendous development. Say, for example, in late 60s and early 70s, there was no CCU. So mortality was 30%. So after the appearance of CCU and defibrillator, it bring down to 15%. And in late 70s and early 80s, because of the development of thrombolytic therapy, the acute MI mortality came down to 10%. And in late 80s and onward, after the development of primary angioplasty, the acute MI mortality has brought down to single digit. It's about 5 to 7%. So there was a tremendous increase in the development and the management of acute myocardial infarction. So in patient with acute myocardial infarction should immediately get hospitalization with a treatment we call MONAC, M-O-N-A-C, M for morphine, oxygen, nitrate, aspirin, and clopidogrel. After loading these things, then you come to the question of reperfusion strategy. Until 2019, we have got three major ways to treat the patient with reperfusion strategy. One is thrombolysis, other one is the primary angioplasty, and third one is the pharmacoinvasive. This is a European Society guideline for the management of STMI. Here you see, after seeing the patient with ECG diagnosis acute MI, if the patient is in a hospital which is having facilities for primary angioplasty, or the patient to nearby distance to the hospital having the primary facilities for primary angioplasty within 2 hours, it should be transferred to that hospital for primary angioplasty. If the distance is more than 2 hours, then he should be treated with thrombolytic therapy, and it should be given within 10 minutes of admission. We call it the thrombolytic therapy. Now you can give the bolus injection of tenecteplase, and after giving these things, if you do an ECG after 90 minutes of thrombolytic therapy, if ECG does not, ST depression, ST elevation does not regress more than 50%, that indicate it was not perfused well. So he should be transferred to nearby PCI facilitated hospital within 2 hours. And other group of patient, whether thrombolyzed successful or unsuccessful, he should be transferred to the PCI capable hospital within 3 to 24 hours. This is the guideline by European Society of Cardiology. And this is the guideline by American College of Cardiology and American Heart Association. Fibrinolytic should be preferred with a fibrin specific like alteplase or tenecteplase as soon as possible within 10 minutes of STMI diagnosis, preferably by pre-hospital, along with adjunctive antiplatelet or anticoagulant therapy. And the patient should transfer to PCI capable center subsequently within 24 hours. And now there's primary angioplasty is a commonly, if it is possible, it should be done within 90 minutes after reaching the emergency department. And those who cannot do these things go for thrombolytic therapy, because every minute is countable and a minute is muscle. There is a third varieties of reperfusion therapy is called pharmacoinvasive. Here I am showing a cartoon with this is pharmacoinvasive. This is a combination of pharmacological therapy with thrombolytics and with invasive procedure by intervention. There is no battle between these two. Rather, combination of these two will definitely give a better result. We call it pharmacoinvasive therapy. So this is all about the ischemic origin of acute chest pain. As I said earlier, I should not forget or I should not miss some other cause of life-threatening chest pain, which includes, apart from ischemic origin, are acute situation like aortic dissection, pulmonary embolism, pneumothorax, etc. So I'll go a little bit about each of these issues. Let us resume a history. A 55 years old, tall, stature, male patient, poorly controlled hypertension, having a history of ascending aortic dilatation previously, experienced severe tearing type of chest pain, radiate to back while lifting a heavy suitcase. On examination, pulse was 100 per minute, blood pressure on right arm was 160 by 100, left arm 120 by 80, and there was early diastolic murmur in aorta. X-ray shows widening of the mediastinum. Echocardiography shows dilated aortic root with grade 2 aortic regurgitation. You will consider that this is nothing but the aortic dissection. I intentionally highlight this risk factor like tall stature, poorly controlled hypertension, aortic root dilatation, lifting of heavy soil. These are the precipitating factor for aortic dissection. As I said, pre-existing aortic aneurysm, uncontrolled hypertension, Marfan syndrome, weightlifting, vasculitis, pregnancy, drug, trauma, cardiovascular catheterization, or aortic intervention like even coarctation of the aorta dilatation or any simple diagnostic catheter can injure aortic wall, leads to aortic dissection. And usually symptom is severe, abrupt, sharp tearing pain, radiate in front if there is dissection in the ascending aorta, or in the back if dissection in the descending aorta. Usually there is a pressure difference on the extremities. There may be a feature of early diastolic murmur of acute aortic regurgitation. There may be weak carotid or brachial pulse. And on X-ray, you will find widening of the chest X-ray. And it will be confirmed by spiral CT angiogram. This is an example. This is the widening of the mediastinum. This is a CT angio. This is the false lumen. This is the true lumen of dissecting aorta. And this is a transesophageal echo showing a false lumen and true lumen in the ascending aorta. So this is the classification of aortic regurgitation. I'm not going in detail. It's commonly type A or type B from the treatment point of view. In general, the goal of treatment is to reduce systolic blood pressure to 100 to 120 systolic pressure, keep pulse rate above 60, and also monitor complication. And it should be antihypertensive drug should be like calcium channel blocker, beta blocker, or even IV nitrate. And for the management, type A lesion, type A type is surgical, type B without complication is medical, type B with complication is surgical or by intervention, putting a cover stent at the dissected place. And for long-term management, should be with beta blocker and also serial imaging at 6 months, 12 months to see the progress of the dissection. This is all about the aortic dissection. Now another history. A 65 years old female having a history of prolonged bedridden for fractured neck femur underwent surgical correction. She developed, she had a previous history of deep vein thrombosis. Suddenly complained of severe chest pain and collapse with profuse sweating. On examination, pulse was 100 per minute, blood pressure 80 by 50. ECG shows sinus tachycardia with multiple PVC. And echocardiography shows RV dilatation. Duplex ultrasound shows deep vein thrombosis. So you can easily can gauge that this is nothing but pulmonary embolism, where the acute pulmonary embolism patient is a spectrum of a disease called venous thromboembolism. Basically, venous thromboembolism starts as a thrombus in the vein of the upper or lower extremities or even pelvis that embolize ultimately lodge in the pulmonary, producing pulmonary embolism. So clinical presentation depends on the burden of the thrombus, degree of occlusion of pulmonary artery, comorbidities, and also basal cardiopulmonary reserve. And these are the primary risk factors for DVT, like idiopathic, age more than 60, hypercoagulable state, obesity, history of previous deep vein thrombosis. Secondary cause like immobilization or paralysis, fracture of the lower limb, recent surgery, pregnancy, oral contraceptive, malignancy, major cardiac illness. These are all the risk factors that precipitate pulmonary embolism. For the management purpose, it can be classified with three on clinical basis, like massive pulmonary embolism, submassive pulmonary embolism, or non-massive pulmonary embolism. The acute pulmonary embolism is massive. In that case, there is sustained hypotension where the pulse is absent or low or feeble. Patients are in state of shock. Submassive effusion, usually pressure is maintained more than 90, but there is also RV dysfunction, elevated BNP or troponin I. And non-massive pulmonary embolism is a low-risk patient, usually hemodynamically stable. And usually the patient present depends on the clinical feature, depends on the size of the embolism. Usually complain of sudden chest pain, dyspnea, faintness, collapse. There may be pleural pain, hemoptysis, and sign may be tachycardia, tachypnea, hypotension, raised JBP. There may be RV gallop or maybe severe cyanosis, depends on the vessel involved. So there are some diagnostic tools need to confirm this, but there should be suspicion on clinical ground, as I said earlier from the history. There can be some laboratory tests that can help you to come to conclusion that it is a pulmonary embolism. Like lab test like D-dimer can increase. There may be raised troponin, there may be raised BNP. On ECG, there may be sinus tachycardia, atrial fibrillation, PVC, right axis deviation, Van branch block, and S1Q3T3. Basically, everybody say about the ECG change, but ironically, only 6 to 15% patient will have this typical S1Q3T3. Most of the cases, it is sinus tachycardia or multiple PVC. On echocardiography, you will find RV dysfunction. There may be a floating thrombus in the pulmonary artery that can also be seen by echocardiography. By CT angio, you can see the filling defect, thrombus within the pulmonary artery or its branches. In MRI, that also can be a tool to identify this, but it has got limitation in a sense. Many hospitals may not have that MRI facilities, and it's also expensive. There is another test, the VQ scanning, that also identifies the ventilation perfusion defect, and also simpler test is duplex ultrasound. If you can detect a thrombus in the lower limb, that also gives a clue that it is pulmonary embolism. Once it is diagnosed, then for the massive or submassive pulmonary embolism, treatment is IV anticoagulation for 5 days with overlapping of oral anticoagulant for 2 days, keeping INR to 2 to 3 times, so long the possibilities of embolism is there. And for the massive pulmonary embolism, you need to thrombolize it by tenecteplase. There is an option of catheter-based mechanical thrombectomy, ultrasound accelerated thrombolysis, and also there is a scope for surgical removal of clot in severe shock patient, although its mortality is very high. In patient with a history of repeated pulmonary embolism and documented thrombus in the lower limb, you can use IV filter for prevention of pulmonary embolism. Now, another history. A patient of 24 years old, male, suddenly developed shortness of breath accompanied with pleural pain that varies with the respiration, more marked at the zenith of the inspiration. So if you take a deep breath, there is a catch hold of breath. And on examination, there is a tachycardia, pulse is more than 100, blood pressure is 100/70, respiratory rate more than 40, means that tachypneic, and chest movement and expansibility is reduced on the right side. There is hyperresonance on percussion note, absence of breath sound on the same side. On X-ray, if you find a collapsed lung and shifting of mediastinum, this is nothing but the spontaneous pneumothorax. Usually, it happens in young patient. associated with sudden shortness of breath and pleuritic type of pain. And as I said, it's very easy to identify if you examine the patient by palpation, percussion, and auscultation. You will find there is absence of the breath sound, percussion or hyperresonance, and expansibility is less on the affected side. And by X-ray, you can easily identify the collapsed thin lung with a thin layer of visceral pleura, and there may be also shifting of trachea on the opposite side, and there may be pleural effusion also, and ultrasound can also help. So for the treatment purpose, it can be simple pneumothorax if it is less than 2 to 3 centimeter. Simple observation is enough. Sometimes, if necessary, you can give oxygen. If it is large, it's more than 3 centimeter, you need to give a needle aspiration and water cell drainage. Or in some time, you can use a chest tube to remove the air for quick resolution. But in large pneumothorax accompanied with the hemothorax, you need a chest drain, water cell drainage with a chest tube. And another rare cause of acute chest pain is rupture esophagus. Here, the patient complains of severe chest pain accompanied with subcutaneous emphysema, pneumothorax, pneumomediastinum, and pleural effusion. And etiologically, it is mostly because of iatrogenic during endoscopic procedure. There may be a situation like malignancy. There may be corrosive or post-radiation perforation leads to a rupture of the esophagus, and rarely a spontaneous esophageal rupture called Borheb syndrome, and it's a triad of symptoms like chest pain, vomiting, and subcutaneous emphysema. Macular's triad, we call it. So this is also a life-threatening situation, need immediate attention. So this is all about the acute situation that one should not miss. There are other categories of chest pain which have got low risk, but also you need to know it, because if you are in emergency department, you should at least diagnose immediately with the character of the pain. One of this is the mitral valve prolapse. Usually, it is sharp left-sided chest pain, accompanied with dyspnea, fatigue, palpitation. Usually, patients are lean and thin female. There may be a chest wall deformity. On auscultation, you may find mid-systolic click or less systolic murmur. An echocardiography is diagnostic to confirm the diagnosis. And in symptomatic patient, beta blocker and reassurance is enough. But if there is associated with severe mitral regurgitation, then you may need to repair it surgically, either by valve replacement or repair, and sometimes by intervention by making a mitral clip. There's another varieties of pain because of pericardia, because pericardial is a pain-giving organ. So if somebody complain of retrosternal pain, continuous in nature, dull in intensity, varies with the movement of the patient, and also varies with the respiratory phase, inspiration and expiration, and also sometimes catch-hold breath during coughing or inspiration, usually associated with pleuropericarditis. So there also you can get a mixed type of pain, both with respiration and on the movement. And also patient get relief if leaning forward. There may be also radiation of the pain to trapezius and back. And this is a ECG of a patient with pericarditis, and you may misguide by the ECG appearance. It could be a acute myocardial infarction, ST elevated impression. But if you look carefully, this ST elevation is not like ST elevated MI as you have seen in myocardial infarction. Its ST elevation is almost all valid. Like there is no definite location as we find it anterior MI or inferior. ST elevation is both in anterior and inferior location. But like here, seeing in lead 1, lead 2, lead AVF, lead 3, V1, V2, V4, V5, V6, means that all the area the ST is elevated, but the ST is combing upward, not convexity upward. This is a feature of ECG feature of pericarditis. Now, for the diagnostic purpose, if you have got chest pain, friction rub with ECG change and pericardial effusion, and you can be out of 4. If you get 2, it is pericardial effusion, pericarditis. And you also consider about the possibilities of cardiac tamponade in patient with pericarditis, because the pericarditis can lead to cardiac tamponade, and sign may be sinus tachycardia, raised JPP, pulsus, paradoxus, Cushman sign, and definitely echocardiography is the diagnostic tool to confirm about the possibilities of cardiac tamponade, which need also immediate attention. In general, pericarditis treatment is NSID, but can also give colchicine or steroids. But you need to monitor the patient by serial ECG, echo, to find out the feature of pericarditis, feature of tamponade, where you need pericardial synthesis. And also, you understand, diagnose for the etiology and treat the underlying cause. Now, chest pain can be also because of esophageal spasm. That also mimic angina pectoris. It may get precipitated by meal, radiates to back. Sometimes it is relieved by sublingual GTN. And mostly it is on supine position after drinking or eating. And a patient has got sometimes a history of reflux, what we call gastrointestinal reflux. Typically, it is retrosternal burning, precipitated by food or supine position, but relieved by antacid, not by GTN. Another common varieties of chest pain is the epigastric pain, or it is because of peptic ulcer disease. It is burning in nature, epigastric location, accompanying with tenderness, and also precipitated by empty stomach, relieved by food, and usually it gives trouble at the late night. It can be relieved by antacid or cold milk or PPI, but not by GTN. This is the differentiating point between cardiac and non-cardiac. Another pain is the biliary colic. It is a constant, lasts for minutes or hours, a deep-seated aching pain. It can be colicky in nature. In the right hypochondrium, you can also get local tenderness called Murphy's sign. And it sometimes referred to the shoulder. And commonly it happened after having a fatty meal. If you take a big Burger King, then you may get a patient complain of pain. There is a possibility because of biliary colic. But it does not relieve neither antacid nor GTN. Simple ultrasonogram is enough to identify this situation. Another common varieties of chest pain is musculoskeletal pain. This is a benign form of pain. It varies with posture, position, accompanied with the local tenderness, and also end at the end of the day. Common causes osteoarthritis, costochondritis, or we call TIS syndrome, usually second intercostal costochondral junction, commonly in the female. And there may be soft tissue injury in the chest. There may be Coxsackie virus infection, or maybe a herpes zoster infection. And especially herpes zoster, you can see there, it runs along the dermatome with the appearance of the vesicle pustule. And even patient can give a history of post-herpes neuralgia. That also referred in the chest. So from the history you can get, and also the marking, the scar mark of this zoster, herpes zoster, can give a clue about the possibilities of herpes zoster. There is another variety, the cervical radiculopathy. It is a constant shooting pain because of the nerve compression. And usually it runs in the dermatome and worsening with the neck movement. This is commonly associated with the cervical spondylitis. And last but not the least is the psychogenic cause of chest pain. It accounts for 25% of the patient presenting in emergency department with chest pain. And it is psychogenic, and pain usually been understood by the physician. Because of the common thing people think about the other non-cardiac causes. But Interestingly, this psychological patient has got some other association like autonomic complaint, multiple presentation, the cluster of physical complaint, a lot of physical complaint, the pain all over the body, it has got no definite relation, and repetitive of history of negative cardiac pathology. Patient will complain of pain, but side by side, he will show some gesture and posture that no, this is not cardiac. Means that negative cardiac pathology. And also his or her clinical profile look like anxiety or panic disorder. And all these things can give you impression that it could be psychological. But keep in mind, after exclusion of all cardiac pain, all pathological pain, after exclusion of all pathological pain, you can consider it as psychogenic. Because if you ignore this pain as psychogenic, there may be a life threatening, which you ignore it can give rise to a fatal outcome. So in conclusion, the chest pain is the most frequent encountered complaint of a patient to a physician. Each disease has its unique pattern of chest pain character, and clinicians should rapidly and promptly assess the chest pain to minimize unnecessary investigation, hospitalization, and cost reduction workup to maximize the patient outcome. The all patient with chest pain should evaluated with history, physical examination, ECG, X-ray, and biomarker quickly to identify as cardiac versus non-cardiac, if cardiac, acute versus non-acute coronary syndrome, and start definitive treatment as early as possible. And one must not miss the life-threatening disease with which the chest pain Thank you very much for your patience hearing. Thank you.
Thank you very much, sir. It's an honor to hear.
Sorry. Yes.
Sir, it's an absolute honor to hear from you. পৃথিবীর সবচেয়ে চ্যালেঞ্জিং টপিকটাই স্যার আপনি টোটাল সামারি করে আনলেন স্যার, ইট ওয়াজ ব্রিলিয়ান্ট। তবে স্যার আপনার পাণ্ডিত্য, আপনার স্কিল এসব নিয়ে স্যার আমি আসলে কথা বলতে রাজি না। আমি স্যার আমাদের ফার্স্ট মিটিং সুনামগঞ্জের টাঙ্গর হাওয়ার, সেটাই স্যার আমার মেমোরিজে আসতেছে। আমি স্যার সবচেয়ে যেটা স্যার ভালো লাগছে স্যার, কারণ প্রফেসর মমিনুজ্জামান এই দেশে একটা মিথ, এই দেশে সবার মানে ওয়ান অফ দ্য মোস্ট সেলিব্রিটি ফিজিশিয়ান, বাট স্যার দ্য ওয়ে ইউ বিহেভড উইথ আস, আপনার যে অমায়িক ব্যবহার, আপনার যে ডাউন টু আর্থ, যাকে বলে যে স্যার মানুষ যত বড় হয় তত ডাউন টু আর্থ হয়, মানে এইসব যে এক্সট্রা অর্ডিনারি স্যার যে আপনার গুণগুলো স্যার, এগুলোই স্যার আমি চেরিশ করতেছি আমার মেমোরিতে। এবং আমরা স্যার যে কয়বারই আপনাকে আমরা স্যার যে কয়বারই আপনাকে প্রেজেন্টেশনের ব্যাপারে অ্যাপ্রোচ করেছি, আপনি এত কাইন্ডলি আমাদের সাথে স্যার কথা বলেছেন, কাইন্ডলি স্যার আমাদের সাথে কোঅপারেট করেছেন, দ্যাট ওয়াজ সো নাইস। এই জন্য স্যার আমি আপনাকে থ্যাংক ইউ জানাচ্ছি অন বিহাফ অফ বোথ দ্য গ্রুপ। স্যার এখন আমি একটু ফ্লোর দিচ্ছি।
Before that, I just want to say thank you very much, because now in the COVID era, I'm not that busy what I was before the COVID situation. I have got ample time, and thank you very much for this talk, because for this I studied, at least I have spent a lot of time that actually helped me. I don't know how much the audience get benefit out of this, but definitely I was really involved in searching the paper, going through the talk. At least it gave me a lot of I should say my own interest. It helps me a lot. Thank you once again to all of you.
Thank you, sir. এবং খুব শীঘ্রই আমরা স্যার আপনার বাঁশির একটা বাদন পেতে যাচ্ছি স্যার, ইনশাল্লাহ খুব শীঘ্রই। স্যার এখন আজকের স্যার প্রচুর কোশ্চেন আছে, কারণ আজকে যারা ভালো কোশ্চেন করবে তাদের জন্য গিফটও আছে, প্রচুর কোশ্চেন জমে গিয়েছে। স্যার কোশ্চেন আনসার পর্বে যাওয়ার আগে আজকের স্পন্সর এসকেপ ফার্মাসিউটিক্যালস লিমিটেডের পক্ষ থেকে মিস্টার আখতার আলম খানকে স্যার আমি ভোট অফ থ্যাঙ্কস দেওয়ার জন্য আহ্বান জানাচ্ছি। মিস্টার আখতার আলম খান, প্লিজ।
Okay, sure.
Thank you, Doctor. Dear sir and dear audience, I am Mohammad Akhtar Alam Khan, Marketing Manager of SK Pharmaceuticals Limited. First, I would like to thank Differential for organizing such a wonderful scientific sessions. Today, we have amongst us a person whom the entire healthcare community admires, who has immense experience in interventional cardiology, coronary care in NICBD and National Heart Foundations, and now serving as the Chief Consultant of United Hospital, Dr. N.A.M. Momenuzzaman, sir. Thank you, sir, for delivering such a nice presentation. Your discussion on evolution of chest pain was really insightful, and I'm sure the audience will be highly benefited from your discussion. Dear Doctor, now I want to tell something about the Escape Pharmaceuticals. You know, Escape Pharmaceuticals is one of the leading pharmaceutical companies, and it is a quality-driven and scientific information-based company. Escape's manufacturing plant is approved internationally by various stringent regulatory authorities such as United Kingdom Medicine and Healthcare Regulatory Authority, that is UKMHRA, TGA Australia, and EU GMP. The company is currently exporting medicines to many countries across the 4 continents, including highly regulated market of Europe and Australia. Dear doctors, knowledge partner of today's session is Isoral Maps, which is the only German tech micropellets esomeprazole of Bangladesh for gastric acidity. Due to the use of German tech, you know, Dr. Isoral Maps ensures faster action with longer duration of action and has dosing convenience because it can be taken with or without food. On behalf of Escape Pharmaceuticals, I want to thank Differential for giving us the opportunity to be the part of today's session. We hope that Escape will get opportunity to be a part of your next scientific sessions as well. And I thank all the participants, and thank you all.
I'm seeing some question. Should I answer this question on the screen? I'm seeing some question.
Sir, just a minute, sir. Just a minute. Dr. Azmiri will contact the session.
Will I start, ভাইয়া?
হ্যাঁ, 20 সেকেন্ড ওভার। হ্যাঁ, আজমেরি শুরু করো।
জি। থ্যাংক ইউ স্যার ফর দ্য এক্সিলেন্ট প্রেজেন্টেশন, এন্ড আমার মনে হয় স্যার সবাই খুব ভালো করে জিনিসগুলো বুঝতে পেরেছে। স্যার, আমি কোয়েশ্চেন সেশনে চলে যাচ্ছি। আমাদের প্রথম কোয়েশ্চেন যিনি করেছেন, উনি নামটি বলেন নাই। ওনার প্রশ্ন হলো, হোয়াট অ্যাবাউট পালমোনারি এম্বোলিজম?
Yeah, thank you. Pulmonary embolism, just a minute. What about pulmonary embolism pain? What about pulmonary embolism pain? Basically, as I told you, pulmonary embolism is severe retrosternal chest pain. The pulmonary embolism pain is the patient otherwise he was or she was having some other complaint associated with this clinical situation. Commonly, pulmonary embolism patient present differently, depends on the amount of embolic clot occluded the pulmonary artery. Sometimes, if there is a small embolization, the patient may not complain of anything. But if it is a big chunk of clot block one of the major pulmonary artery, then patient complain of severe retrosternal pain with feature of sign symptom of shock. So this is like acute coronary syndrome like pain. But how can you differentiate these things? Simple. If this patient, if you do an ECG, you will find not like what we find in acute coronary syndrome like STT changes, because any patient if come with the shock but normal ECG is at least it is nothing related with ischemic coronary disease, something else. So it's some form of exclusion wise you should separate this pulmonary embolism from other. That is the reason pulmonary embolism is many a time it is undiagnosed in a hospital setting, because chronic debilitated patients lying flat in the bed, suddenly he or she complain of acute collapse. And if you do an ECG, you will not find anything other than sinus tachycardia, atrial fibrillation, or PVC. But patient is in a state of shock, sign symptom of cyanosis, low blood pressure, high pulse rate. So these are the clinical feature of the pulmonary embolism. And also you
Thank you,
should
sir.
associated precipitating factor like there's a history of recent surgery, or if there is obesity, or if the patient has got previous history of deep vein thrombosis. These are the precipitating factor with which you can identify. Yes.
থ্যাংক ইউ স্যার। স্যার প্রশ্ন করেছেন বুদ্ধদেব গাঙ্গুলি। স্যার উনি অনেকগুলো কোয়েশ্চেন করেছেন, আমি কিছু
Sure.
আপনাকে প্রথমে দিচ্ছি স্যার। থ্যাংক ইউ স্যার। How will we identify it is acute coronary syndrome? Because we sometimes found non-STMI and STMI. And when we say non-STMI, because sometimes we found ischemia, which ischemia or ischemic change we consider as acute coronary syndrome. স্যার আপনি তো acute coronary syndrome সম্পর্কে অনেক কিছুই বলেছেন, অনেক কিছু এটাতে ক্লিয়ার হয়ে এসেছে। তারপর স্যার যদি কিছু
I've shown the animation of the animation that actually give you the idea what is non-STMI, what is STMI. When you say non-STMI means it is myocardial infarction. It is myocardial infarction, but not associated with ST elevated MI. Why this difference between STMI and non-STMI? Because STMI patient has got a treatment algorithm different from non-STMI. For ST elevated MI, we should thrombolize the patient, revascularize the patient. But in non-STMI, it is subtotal occlusion of coronary artery. Here, the chance partially occluded coronary artery, there is still some flow going on. So there is not complete occlusion. Give rise to this sort of presentation. Here you will find maybe STT changes, maybe ST depression, but associated with enzyme biomarker will be high. This is the difference between non-ST with unstable angina. Unstable angina, you will get the similar type of pattern ECG changes, but there is no muscle damage. So here also the treatment of unstable angina and non-STMI more or less same. Start with loading dose of aspirin clopidogrel, then low molecular weight heparin. I think difference between axis, difference between SCS and MI, as I told. Why do we give 2B3A inhibitor? We mainly use non-STMI, but non-STMI. Why this is reason? Yes, very good question. The patient with acute MI, treatment is revascularization because there is a occlusive thrombus that completely occlude the vessel. So your main intention to open the vessel either by pharmacology, by thrombolysis, or by mechanical, by angioplasty, or combination. GP2B3A is the drug usually given in non-STMI. Because it is not thrombolytic. Mind it. Thrombolysis and antiplatelet is different. GP2B3A is antiplatelet drug. But in acute MI, we need a thrombolytic therapy because that is a clot consist with platelet fibrin combination. But in subtotal occlusion, there is a lumen through which the blood is passing. Here, the role of thrombolytic therapy is not there. Here, you can use antiplatelet therapy, either aspirin clopidogrel or 2B3A or low molecular weight heparin. This is the reason we don't use it for acute MI.
থ্যাংক ইউ স্যার। স্যার আমাদের ফেসবুক চ্যাটে এবং আপনার কোয়েশ্চেন অ্যান্সার যে আমাদের এটা আছে, ফ্লোরটা আছে, আমাদের সব জায়গায় অনেকগুলো কোয়েশ্চেন এসেছে। তো আমি অন্য পার্ট গুলোতে চলে যাচ্ছি স্যার। ফেসবুকে কিছু প্রশ্ন এসেছে, আর কোয়েশ্চেন অ্যান্সারে আরো কিছু প্রশ্ন এসেছে। ডক্টর বাশার প্রশ্ন করেছেন, 55-year-old diabetic male presented with severe central chest pain for 6 years. How will we manage this patient in Upazila Health
Yes.
Complex?
Very good question, because this is a 55 years old diabetic male patient present with a severe retrosternal pain. The very history suggestive, yes. First diagnosis should be, is it a cardiac origin or non-cardiac? Because you are in Upazila, from the clinical point of view, the clinical diagnosis is the chest pain character. If it fit with coronary related, then you'll be asking for a ECG. I think in Upazila you will have a facilities for ECG. If you don't have ECG, then what you will do? That is another question. A diabetic patient presented with severe central chest pain for 6 hours. First diagnosis should be acute coronary syndrome. In that case, you just give a loading dose of antiplatelet, aspirin and clopidogrel, if not contraindicated. Then immediately you do go for an ECG, ask for an ECG. If ECG is not available, as patient has got severe chest pain, you definitely refer to patient to a place where at least a ECG can be done. That ECG will guide whether he need a hospital admission for the management of acute coronary syndrome, if at all, or non-cardiac cause. That it will give you a clear idea, ECG and possibly by troponin. And Upazila, I think troponin may not get you, but ECG wise you will get at least some support. Yes.
Thank you, sir, for the answer. So, Dr. Shaikh bolchen, in Upazila Health Complex, where proper patient referral sometimes not possible, no facilities for PCI or thrombolysis. In this situation, can we manage an acute MI patient with low molecular weight heparin?
Yeah, that is another good question. And actually, I am planning, we are cardiologists are planning to do campaign on management of acute MI in the periphery, because now there is drug tenecteplase. Tenecteplase can be given a bolus injection within bolus IV can be given in the periphery. So if you can diagnose the acute microinfarction, you can give bolus dose of tenecteplase. But before that, definitely you load the patient with aspirin and clopidogrel loading dose, 4 tablet aspirin, 4 tablet clopidogrel. Then you start with thrombolytic. If not possible, definitely you can give a dose of low molecular heparin and immediately shift the patient to a place where the advanced facilities is there, because within first 12 hours there is a good chance of thrombolytic therapy. Even if you cannot give any treatment within first 24 hours, at least if you can send the patient to a place where there is a chances of invasive procedure, even the patient can be benefited with invasive procedure within 24 hours. But first you try with thrombolytic therapy, if possible with a bolus dose of tenecteplase, refer the patient to a place where the advanced treatment is available.
Thank you, sir. He has another question. He has added, what will be the loading dose of atorvastatin while referring the patient?
Actually, there is a study says that atorvastatin has got some anti-inflammatory role. For that reason, usually 80 milligram atorvastatin is given as a loading dose. It is not a typical a class 2A indication. It's a helpful. It has been shown by some studies that it is benefited if you give a loading dose of 80 milligram atorvastatin.
Thank you, sir. Thank you so much. Sir, Facebook থেকে আমাদের আরেকটি কোশ্চেন আছে। ইসরাত আরা প্রশ্ন করেছেন, I'm a third year medical student. I would like to ask a question to our honorable sir. My mother has recently recovered from COVID-19, but now she is suffering from left-sided chest pain, compressing type. It is aggravated by standing up, walking, working, and relieved by taking bed rest. Her ECG was tested normal. I have seen many COVID recovered patients are complaining of this kind of pain. I want to know the cause and what should be the treatment. It is musculoskeletal pain or related to myocarditis or some cardiac disease or other. What should we do in this
That's
situation?
very intelligent third year student having so much of knowledge about. Yes, probably she must have gone through some of the textbook on the effect of COVID on the heart. Yes. From the history, I don't know about the risk factor, but the chest pain, uh, if it is coronary, because COVID patient are not immune of acute myocardial infarction or acute coronary syndrome, but COVID patient after recovery, there are some residual sequelae of uh, mm, COVID infection that leads to some form of fibrosis in the lung that can give rise to pleuritic type of pain. There may be a pericarditis that can also give rise to pain. There may be musculoskeletal pain, but definitely, if you inquire about the other risk factor like hypertension, diabetes, then you can investigate the patient with other investigation like echocardiography, dobutamine stress echo, because after recovery it will be not easy for her to do a treadmill test. Maybe after 3 to 4 weeks, once she recover well, then you can investigate with echo and treadmill test.
Thank you, sir. Thank you for the answer. Sir, I'm giving floor to Ehsan Bhaiya, Dr. Ehsan Bhaiya.
স্যার একজন লাইভ কোশ্চেন আছে, স্যার একজন লাইভ কোশ্চেন করতে যাচ্ছে স্যার, ডক্টর সঞ্জিদা আলম স্যার আপনাকে লাইভ কোশ্চেনে আনতে যাচ্ছেন। ডক্টর সঞ্জিদা, প্লিজ। Dr. Sanjita, can you hear me?
Yeah, thank you.
Okay, your question, please.
Yes.
আসসালামু আলাইকুম স্যার। স্যার
Yes,
আপনার
Sanjida.
মানে সাথে আমার দেখা কখনো হয়নি, কিন্তু আমার আব্বুর মানে অপারেশন কিন্তু আপনার কাছেই করা। আপনার সম্পর্কে আমি অনেক শুনেছি আর কি।
Thank
আর
you.
আমি আসলেই অনেক লাকি আমি আজকে আপনার সেশন লাইভে পেয়েছি।
Thank you.
স্যার আমি চিরাং মেডিকেল থেকে এবার ফাইনাল মানে ইন্টার্নি শেষ করলাম।
Good.
আর স্যার স্যার এই আমরা যে কার্ডিয়াক পেইন নন কার্ডিয়াক পেইন আলাদা করলাম, এখন নন কার্ডিয়াক পেইন, হ্যাঁ আমি যখন আলাদা করতে যাব ইন উপজেলা হেলথ কমপ্লেক্স, আমি স্যার জিটিএন স্প্রে বা হচ্ছে এই ধরনের মানে যে প্রসিডিওর গুলো ওইগুলো কতটুকু স্যার মানে ওইখানে যৌক্তিক হবে? মানে আমি পেশেন্টটাকে রেফার করার আগে কি কোনোভাবে এভাবে ম্যানেজ করে পাঠাবো, নাকি স্যার মানে নিজে সেফ সাইডে থাকবো?
মোমেন স্যার হ্যাং হয়ে গেছে মনে হয় স্যার একটু।
কেমন আছেন ভাইয়া?
মোমেন স্যার, প্লিজ।
আরে নেটওয়ার্কটা একটু দুর্বল আছে, আমরা আমাদেরকে জানি স্যার তো অফলাইন হয়ে গেছেন স্যার।
আসলে
কোশ্চেনটা ছিল যে যে উপজেলায় চেস্ট পেনের ম্যানেজমেন্ট, তাই তো?
জি স্যার।
না, এখন উপজেলা আমার মনে হয় যে এখানে ক্লিনিক্যাল আইটাকে শার্ট করতে হবে, বিকজ উপজেলা লেভেল ইউ মে নট হ্যাভ এ ফেসিলিটিস ফর biomarker.
ECG.
So at least ECG will be there. So first of all, the symptom. If the typical symptom accompanied with associated symptom of acute coronary syndrome, as I said, chest pain, associated symptom like palpitation, shortness of breath, and if it associated with some coronary risk factor like hypertension, diabetes. So with all these things, you at least probable diagnosis should be made whether it is acute coronary syndrome or non-cardiac. Otherwise, you have got little chance to confirm diagnosis. Yes, if it is ST elevated MI or there is STT changes, it is more sure it is of cardiac issue. In that case, you will just give loading dose of aspirin clopidogrel, and that is enough for you at that area. And if it is acute MI, then you can take, as I said earlier, the use of bolus dose of tenecteplase. Okay.
স্যার মানে কনফার্মেশনের আগে জিটিএন ইউজ করাটা কি মানে আমাদের পক্ষে মানে ইজি, মানে আমরা কি চাইলে এটা করতে পারবো?
কোনটা?
মানে কনফার্মেশনের আগে আমি জিটিএন ইউজ করে দেখলাম এটা কার্ডিয়াক নাকি নন কার্ডিয়াক।
That is GTN sublingual. GTN is another test, but esophageal spasm also can get relief of chest pain. That's what I'm saying. Not only the chest pain is totality, chest pain character, its location, radiation, aggravating factor, relieving factor, associated symptom, associated with coronary risk factor. So all together you can come to a conclusion along with ECG. If there is facilities for enzyme, then you can add with.
Yes. Thank you, sir.
Thank you.
Thank you.
Next question, please.
Next question করেছেন শামিমা আক্তার, how to differentiate between chest pain caused by aortic dissection from esophageal rupture?
Yes, I think I have given a very clear information about these two. Esophageal rupture, it is a severe pain accompanied with subcutaneous emphysema, pneumothorax, pneumomediastinum. This is the characteristic feature of esophageal rupture. And in case of acute coronary syndrome, that is something different. I think I have described this. I want to share this too. Just a minute. Severe chest pain, shock, subcutaneous emphysema, pneumothorax, pneumomediastinum, Reperfusion, and associated. These are the association. Commonly iatrogenic, and sometimes it is spontaneous, where there is a triad of symptoms like chest pain, vomiting, and subcutaneous emphysema. Yes.
Thank you, sir. জি স্যার। স্যার আমি পরের প্রশ্নে চলে যাচ্ছি। আমাদের পরের প্রশ্নটি করেছেন ডক্টর সাইদুর রহমান সাইদ। প্রশ্নটি হলো, why troponin I raises during pulmonary embolism? Normally, we know during MI like non-STMI or STMI. And the second question, why we need to thrombolysis during STMI but no need thrombolysis during non-STMI?
I think this question
দিয়েছেন জি স্যার।
এর আগে একবার দিয়েছি। ওর কোশ্চেন হচ্ছে যে আরেকটা কোশ্চেন হলো যে ট্রোপোনিন আই পালমোনারি এম্বোলিজমে বাড়ে কেন? ফাইন। ট্রোপোনিন আই শুধু যে acute coronary syndrome myocardial damage বাড়ে তা না। There are number of cases, number of clinical situations where troponin raise directly in case of pulmonary embolism. If there is severe massive pulmonary embolism, there is stressing of the cardiac chamber. That's why there is raise in the troponin I and also BNP. These two enzymes raise because of massive pulmonary embolism. But here not like that happen in acute myocardial infarction. The troponin raise here is maybe say high sensitivity troponin maybe 500 or 1000, but in acute MI it will be like 15,000, 20,000. This is because of acute dilatation of the heart chamber, especially the right heart chamber, leads to raise in BNP and troponin I. Got it?
Yes, sir. Thank you, sir. আমি পরের প্রশ্নে চলে যাচ্ছি। প্রশ্নটি করেছেন মৌসুমী আক্তার। Thank you, sir. My question is how to differentiate pain between aortic dissection and inferior MI.
Aortic dissection and inferior MI. Inferior or anterior matters little in terms of acuteness. Acute MI, inferior or both the situation. In acute MI, inferior, as you said, specifically inferior, commonly retrosternal pain, hypotension. There may be bradycardia. ECG will say ST elevated in 2-3 AVF. Troponin will raise. This is on one end of inferior MI. If you consider the aortic dissection, the severe tearing pain may be anterior because of ascending aorta dissection, or posterior because of descending aorta dissection, and accompanied with hypotension, difference in pressure on either hand, maybe pulse variation in the carotid or femoral, but there is no ECG change of, usually, I will not say never, usually ECG change is not like inferior MI, except one situation, if the dissection progressed to involve the coronary artery, then only you will get both dissection and inferior MI. This is very, very rare because dissection of aneurysm can dissect downward to produce aortic regurgitation and occlusion of coronary ostium. In that case, you will get both the feature of dissection clinically and by ECG with ST elevation.
Thank you, sir. Thank you for the excellent answer, sir. I'm going to the next question, sir. And it is done by Dr. Mohammad Istiak Bokht. Please justify use without confirmation emergency use of GTN, ecosprin, atorvastatin.
I'm sorry, question again. Emergency
Please
use
justify, sir, please justify use without confirmation emergency use of GTN, ecosprin, and atorvastatin.
Now, I see always risk and benefit, because these three drugs, it not like the drug that will itself produce a gross side effect. But if you diagnose a patient with suspicion, great suspicion that yes, there is a possibility of acute coronary syndrome, there's no harm to give sublingual GTN, no harm to give atorvastatin, no harm to give aspirin, because these three is not life-threatening compared to acute coronary syndrome that is life-threatening. So always judge from the history. If you feel yes, it is justified, it is rational to give these three drugs, because the possibilities of acute coronary syndrome from your history and clinical finding is justified to give this drug. Say for example, at a young, say 15 years old, a girl complaining of chest pain, definitely will not give GTN because probability is low. But if somebody of 45 years male is hypertensive or diabetic having chest pain, you don't have an ECG, but probabilities of ischemic heart disease are high. In that case, it is justified to try with the GTN. If it relief, yes, it is more justified, it is more rational to give aspirin and atorvastatin.
Thank you, sir. Thank you so much for the answer.
Thank you.
Sir, I'm going to the next question. টি করেছেন Sarwar, sir, how can we prevent the incidence of pulmonary embolism following major lower limb surgery?
Yeah, here as I said, If you consider the probabilities of pulmonary embolism, who are the probable person? Number one, the prolonged bedridden, immobilized, seriously ill patient, and an acute illness, underwent surgery, with a previous history of DVT or other thromboembolic or hypercoagulable status. These are the predisposing factors. If you feel that predisposing factor is high, then you can give a prophylactic, not therapeutic, prophylactic dose of anticoagulant, low molecular heparin. So this is the risk factor or DVT. The obese, history of previous DVT, then you can use low molecular heparin 40 milligram OD. That is one way you can use for the patient with your pulmonary embolism. Yes.
Thank you, sir. Thank you so much for the elaborative answer, sir. I'm taking next question. Dr. Murad Mahmoud bolchen, sir, what single examination, how to differentiate of chest pain of cardiac or musculoskeletal origin?
Musculoskeletal pain commonly is accompanied with local tenderness. If it is musculoskeletal, just press finger point. You can pinpoint the pain. Usually, I always tell to my patient and also everybody, cardiac pain usually cannot be pinpointed. If somebody says that I am having chest pain here, exactly pinpointing by tip of the finger, it is non-cardiac. Cardiac pain usually been shown by thumb, the stress thumb. This is like this, whole chest. This is also a pathognomonic sign, a patient with ischemic origin. But if he says this, usually musculoskeletal pain you can localize. Okay.
Thank you, sir. Thank you so much. স্যার আরেকটি প্রশ্ন ছিল স্যার মুরাদ আহমেদের স্যার উনি প্রশ্ন করেছেন what single examination how to differentiate of chest স্যার সরি স্যার এই কোশ্চেনটা আমি আবার পড়ে ফেলেছি if patient on thrombolytic therapy then what is criteria and time for elective PCI?
Okay, there is a two way as per guideline. Thrombolysis, after thrombolysis, there is a two option. One, if you see that the ECG and not regress more than 50% within 90 minutes, that indicate it is unsuccessful thrombolysis. So you need to do rescue PCI, and that rescue PCI should be done within 2 hours. This is a very clear guideline, European Society of Cardiology. If after thrombolysis unsuccessful, do angioplasty within 2 hours. Second option, pharmacoinvasive. Pharmacoinvasive patient should be done within 3 to 24 hours after thrombolysis. So this is the second category. Say for example, the patient spend their time over 24 hours. Then what will be the next step for invasive approach? That depends on the clinical situation of the patient. You categorize the patient on scoring system, TIMI score. There is a scoring system, TIMI score. In this score, if the patient fall on intermediate or high risk, usually we call high risk like persistent chest pain accompanied with hypotension, need inotropic support, or patient having heart failure that needs immediate intervention no matter the time. even after 24 hours. So high risk and intermediate patient should go for invasive approach in hospital. So 3 category. Say for example, you have got all facilities in your hospital for thrombolysis, for rescue, for pharmacoinvasive. But for some reason, you fail to do primary angioplasty, you have got option of thrombolysis immediately, then check the ECG. If it is unsuccessful, do within 2 hours invasive approach. If successful, do angioplasty within 24 hours. Even after 3 days, patient, you have not done anything. After 3 days, patient develop persistent chest pain, having hypotension, having heart failure, you should go for invasive. Okay, patient don't have any symptom after thrombolysis, remain at hospital uncomplicated, low TIMI score, discharge the patient and do the procedure after 4 to 6 weeks with some pre-invasive investigation like treadmill test or dobutamine stress echo. So these are the guideline. Okay.
জি স্যার, থ্যাংক ইউ স্যার। আসলে আমাদের কাছে এত এত প্রশ্ন এসে গেছে, সবগুলো তো আসলে করা সম্ভব না, কারণ আমাদের সময়
No problem,
অনেক বেজে
no
গেছে,
problem.
অনেক রাত হয়ে গেছে স্যার। আমি একটু এহসান ভাইয়াকে
দেড় ঘন্টা।
ফ্লোর দিতে চাচ্ছিলাম। জি
Sir, thank you
এহসান ভাইয়া।
again, sir. Sir, thanks a lot again, sir. It's an honor. আর স্যার আমাদের বোথ দ্য গ্রুপ বিডি ফিজিশিয়ানস এন্ড ইসিজি স্টাডি গ্রুপের যেটা সবচেয়ে ভালো লাগতেছে যে ডক্টর মোমেনুজ্জামান স্যারকে আমরা পুরো জাতির সামনে এনে হাজির করতে পারলাম। সারা জীবন
Thank you.
সবাই আপনার নামেই শুনছে
Thank you.
ডক্টর মোমেনুজ্জামান, কিন্তু হয়তো আমরা এই জন্য সৌভাগ্যবান মনে করতেছি নিজেদেরকে যে স্যার আমাদের কল্যাণে হয়তো স্যার আজকে পুরো দেশের সেই টেকনাফ থেকে তেতুলিয়া ফিজিশিয়ানরা স্যার আপনার কথা শুনছে, আপনার কাছে লাইভে দেখছে, এজন্য স্যার আমরা নিজেদেরকে সৌভাগ্যবান মনে করছি। আর স্যার থ্যাংক ইউ, কিন্তু আপনাকে থ্যাঙ্কস দিয়ে শেষ করতে পারছি না, কারণ আপনার সাথে আমাদের ভবিষ্যতে
হ্যাঁ, নিশ্চয়ই,
আরো অনেক
নিশ্চয়ই,
অনুষ্ঠান
নিশ্চয়ই,
করার ইচ্ছা আছে।
নিশ্চয়ই।
ইনশাআল্লাহ
Love
স্যার
to
আবার
be with
দেখা
you.
হবে। স্যার এখন
And I'm
স্যার
delighted with
both
your service in Sylhet. We will never forgettable situation. And কোভিড চলে
ইনশাআল্লাহ
গেলে
স্যার
ইনশাআল্লাহ আবার যাব, টাঙ্গুয়ার হাওরে আবার যাব।
ইনশাআল্লাহ স্যার
হ্যাঁ,
ইনশাআল্লাহ স্যার কোভিড যখন শেষ হবে প্রকৃতি তো স্যার এখন
চাঁদনি রাতে
নতুন,
বাঁশি বাজায় শোনাবো, যাও।
ইনশাআল্লাহ স্যার। আর প্রকৃতি তো স্যার এখন আরো সুন্দর হইতেছে স্যার, সে তো আরো নতুন রঙে সাজতেছে, তখন স্যার আরো সুন্দর
হ্যাঁ,
থাকবে স্যার।
নিশ্চয়ই,
ইনশাআল্লাহ আমরা
নিশ্চয়ই।
ইনশাআল্লাহ আবার যাব। তো স্যার ফ্রম বোথ ডক্টর আজমিরি এন্ড ডক্টর এহসান, আমরা দুইজন স্যার
Yeah,
আপনাকে
thanks
দিয়ে
Asmiri
শেষ
for
করছি
well
স্যার।
conduction of this program. Thank you very much. Thank you যারা শুনছো সবার জন্য শুভেচ্ছা, সুস্থ থাকো, ভালো থাকো, ধন্যবাদ, আসসালামু আলাইকুম।
আসসালামু আলাইকুম স্যার।
সবশেষে বিডি ফিজিশিয়ানস ইসিজি স্টাডি গ্রুপ
Yes,
দুই
BD
পক্ষ থেকে
physician.
ধন্যবাদ, এবং এসকে ফার্মাসিউটিক্যালস লিমিটেডকে
Yes,
তাদের
same
স্পন্সরশিপের
from
জন্য
my
ধন্যবাদ।
side, same
এবং
from
স্যার
my side.
আমাদের স্পন্সরশিপে তারা স্যার আমাদেরকে একটা গুড নাম্বার অফ মাস্ক দিচ্ছে এবং বুক দিচ্ছে স্যার। সো থ্যাংক ইউ
Thank you very
এভরিবডি
much.
স্যার।
Thank you,
Thank you,
আসসালামু
sir.
আলাইকুম।
আসসালামু আলাইকুম স্যার। থ্যাংক ইউ স্যার, থ্যাংক ইউ স্যার।
আজমির লিভ নিয়ে নাও। আক্তার সাহেব প্রোগ্রাম শেষ করে দেন, আমরাই কথা বলি।
জি
প্রোগ্রাম
থ্যাংক
শেষ
ইউ,
করে
থ্যাংক
ফেলেন।
ইউ, থ্যাংক ইউ, জি থ্যাংক ইউ, থ্যাংক ইউ।
আক্তার সাহেব প্রোগ্রাম তো শেষ নাকি?
হ্যাঁ জি জি শেষ শেষ, থ্যাংক ইউ।
তাহলে মিজান ভাইকে একটু আনেন না, মিজান ভাই আছে নাকি জুমে? এখন তো আসতে পারে, মিজান ভাই আছে দেখেন তো
স্যার
আশেপাশে?
মিজান স্যার তো নাই এই মুহূর্তে, আসলে এখনো নাই স্যার।
মানে কোনো চিপাই চাপাইও নাই?
স্যারের সাথে আমার ফোনে কথা হয়েছে, এইখানে নাই স্যার, একটু পার্সোনালি
এখন আমরা আড্ডা দিতাম, এখন তো শেষ, প্রোগ্রাম তো শেষ না।
স্যার আমি ঠিক আছে স্যার, রাত হয়ে গেছে তো স্যার, আমি স্যারকে জানাবো স্যার, আপনার সাথে যোগাযোগ করে দেবো।
বাংলাদেশে তো প্রেজেন্টার বহুত আছে, মোমেন্ট স্যার, আতিক স্যার এই লেভেল রিয়ার,
জি স্যার,
এই লেভেল হলো আনবিলিভেবল। এই যে মোমেন্ট স্যারের কথাবার্তা এইগুলো হচ্ছে মানে পুরো ইন্টারন্যাশনাল স্ট্যান্ডার্ড।
জি স্যার, সবাই অনেক কোশ্চেন স্যার দেখতে পাচ্ছি, হিউজ রেসপন্স
না
স্যার।
হয়েছে কি, বেশি করলে পেঁচায় যেত, প্রোগ্রামের টেম্পো নষ্ট হয়ে যেত।
জি স্যার।
হ্যাঁ, আর যেহেতু গিফট টিফট আছে তো পোলাপান আরো কোশ্চেন করতে চাইছিল, আমি রিপিট করতেছি এখান থেকে মেসেঞ্জারে সবাইকে, ভাই আর পাঠায়ও না, আর পাঠায়ও না।
জি জি স্যার, থ্যাংক ইউ স্যার।
থ্যাংক ইউ
স্যার আমরা নেক্সট আবার থাকবো স্যার, আমাদের এনি টাইম আপনার সাপোর্ট চাই স্যার।
আচ্ছা, আরে দেখেন এই যে এই মাত্র আমাকে করে ফেলছে আবার, ওই যে আমাদের সিলেটে মতিউর রহমান স্যার একজন আছে, নাম শুনছেন হয়তো, নিউরোমেডিসিন
জি
স্যার, তো মানে লিজেন্ড,
জি
মানে স্যারকে তো মানে এই সার্বিয়ার যে স্যারকে কপচায় ফেলছে বুঝছেন।
জি
এখন সার্বিয়ার বলছে স্যার আমরা তো মতিউর রহমান স্যারের প্রোগ্রামটা আপনাদের সাথে করবো। আমি বলি ভাই তোমরা আবার কোত্থেকে আসলা?
জি
আমার তো এসকেএফ আর হেলথ কেয়ার আছে, তোমরা কোচিপা থেকে
স্যার। আপনার কি কোনো মানে কোন কোন স্যারের সাথে নেক্সট যাচ্ছেন এমন কোনো শিডিউল কি পাইতে পারি স্যার?
না, আমার যেটা 12 তারিখটা আসলে আতিক স্যারের সাথে হেলথ কেয়ার কথা বলে ফেলছে। আর 17 তারিখ আছে প্রফেসর সালমা সুলতানা।
জি
প্রফেসর সালমা সুলতানা ঢাকা মেডিকেল কলেজের সার্জারির প্রফেসর, এবং ম্যাডাম ইজ টু গুড।
জি স্যার, তাহলে আমরা ওইটাতে থাকি স্যার।
আচ্ছা আচ্ছা, ওইটা তো আপনাদের রাখবো, ঠিক আছে। আমাদের তো এখন
আচ্ছা
সবাই আসতেছে দেশের, বুঝছেন। এফ এম সিদ্দিকী স্যার তো আজকে স্যারের ওয়াইফ একটু অসুস্থ,
জি
বুঝছেন।
জি স্যার।
না, আমাদের তো আল্লাহ রহমত হয়েছে কি, যেমন ধরুন কিছু মানুষ তো আমরা যখন বলি আসতেছে, কারণ আমাদের সবাই ট্রাস্ট করে কেন, এই যে আমরা যে কাজগুলো করতেছি সবাই তো দেখতেছে যে আমরা তো ধান্দাবাজি করতেছি না।
জি জি
এবং আমাদের তো সামনের মাসে পাবলিকেশন, প্রথম পাবলিকেশন আসতেছে জলিল স্যারের। জলিল স্যার বের করতেছেন হচ্ছে টিউবারকুলোসিসের উপরে। তারপরে চিটাগাং এর প্রফেসর প্রদীপ কুমার দত্ত একজন আছে, হয়তো নাম শুনবেন,
জি
চিটাগাং এর।
জি জি
উনি হাইপার টেনশনের একটা গাইডলাইন করে দিচ্ছেন। তারপরে সাজেদা সেলিম স্যার ডায়াবেটিসের একটা গাইডলাইন করতেছেন। আমাদের অনেক পাবলিকেশন আসতেছে।
জি স্যার, তাই তো খুবই ভালো, মাশাআল্লাহ।
হ্যাঁ, আমরা আমরা হচ্ছে কি, আমরা এবং আমরা খুব ইন্টারন্যাশনাল স্ট্যান্ডার্ডে জিনিসটাকে গুছানোর চেষ্টা করতেছি। মানে আছে না যে যারে তারে ধরে একটা
জি না না
প্রেজেন্টেশন
না,
করে
জি
ফেললাম।
সব
আমার
রিনাউন্ড
কথা হলো
রিনাউন্ড স্যাররা।
আমার কথা হলো ভিউ ইজ নট অলওয়েজ ম্যাটার, বুঝছেন।
জি
ওই
জি
হিরো আলমের ভিউ কয়েক মিলিয়ন আছে, অপু ভাইয়ের ভিউ 10 লাখ হয়ে যায়, বুঝছেন।
জি জি জি
ভিউ অলওয়েজ ডাজন্ট ম্যাটার, কোয়ালিটি ম্যাটার। আমি
জি জি
আমি অলওয়েজ কোয়ালিটি দেখি। এই জন্য আমাদের গ্রুপটা এত র্যাপিড ফ্লারিশ করে গেছে। 3 মাস হয় নাই, এখন 6000-এর উপর চলে গেছে, এবং বেসিক্যালি শুধু ডাক্তারদের নিয়ে।
জি জি জি
আর আমাদের
জি স্যার।
আরেকটা গ্রুপ যেটা সিসিজি, ওইটাতে তো 45,000 আছে।
ওরে বাবা
আমাদের
জি
মোটামুটি
স্যার।
একটা ভালো ওয়ার্ক ফোর্স আছে। ঠিক আছে, একটা
জি
শেফ,
স্যার,
থ্যাংক
জি
ইউ।
স্যার, থ্যাংক
কালকে
ইউ,
আপনার
থ্যাংক ইউ
সাথে
ভেরি
দেখা
মাচ।
হবে।
জি জি
আর আপনি আমাদের ওই যে গিফট গুলো
আমি
একটু খেয়াল
পাঠিয়ে
রাখেন।
দিচ্ছি স্যার। কালকে আমাদের অফিস বন্ধ আছে, পরশুদিন স্যার।
আচ্ছা আচ্ছা আচ্ছা,
কালকে
থ্যাংক ইউ
আমাদের
আপনার
অফিস
স্যার।
বন্ধ আছে, ক্লোজ আছে
আচ্ছা
জন্মাষ্টমী উপলক্ষে, পরশুদিন
আচ্ছা
স্যার।
আচ্ছা
জি স্যার,
আচ্ছা, থ্যাংক
ওকে,
ইউ,
জি
থ্যাংক ইউ
জি
আপনার।
জি, আসসালাম।
ওয়ালাইকুম আসসালাম।